We've got two great cases lined up for me today. I'd like to invite Professor Rory McConn-Walsh and his team, Mr. Owen Clear, from the ENT Head and Neck Department here at Beaumont Hospital. Rory does a lot of skull-based work, and he or Owen are going to talk to us about contemporary management of post-traumatic facial nerve paralysis. And I therefore invite Owen to share his slides. Thank you.
Thank you, David. Thank you, Owen.
Perfect. Now, just want to check, is that sharing okay for everyone?
Yep.
Perfect. So good evening, everyone. Thanks very much for the opportunity to present today. I'm delighted to present on behalf of Professor McConn-Walsh and the ENT department here in Beaumont Hospital pertaining to the contemporary management of traumatic facial nerve paralysis. So I'm going to start off by talking about a couple of cases before we discuss the management of these cases in a bit more detail. So our first case is AM, who's a 55-year-old lady. She presented initially to the emergency department after falling down a flight of stairs and hitting her left occipital-parietal area. She'd no loss of consciousness at the time, and she didn't have any nausea or vomiting or any alcohol on board. Her GCS was 15 out of 15 on arrival, and you can see her past medical history here on the right-hand side. On examination, she had a laceration behind her left ear and numbness surrounding her left ear. She also had left-sided bloody otorrhea. Otoscopy was performed and showed a distorted external auditory canal on the left and a tympanic membrane perforation. She was noted to have a House-Brackman grade 6 facial nerve paralysis on arrival, and she was otherwise neurologically intact. CT of her brain and temporal bones was arranged, and as you can see here on the findings, she has a left-sided transverse temporal bone fracture traversing the facial nerve above the stylomastoid foramen, and you mightn't be able to quite appreciate it, but on the scans it was also evident that she had a disarticulated incostapedial joint. So she'd no intracranial pathology on her CT of her brain, so she was referred to ourselves by the emergency department. She was initially started on high-dose steroids, 60 milligrams of prednisolone. We consulted ophthalmology for eye care, considering she had no movement in her facial nerve. Audiometry was performed, which showed a conductive hearing loss of around 30 decibels in that left ear. And she had electrophysiologic testing on day 3, which showed no signal in the facial nerve. So a decision was reached to explore her facial nerve and decompress or repair the nerve as necessary. She underwent a left-sided combined approach tympanoplasty, and she had her vertical segment of her facial nerve decompressed. Bone pate was used to repair her external auditory canal defect, and she had an incus transposition graft and a cartilage tympanoplasty. She recovered very well postoperatively with her facial nerve function improving to House-Brackman grade 1 or normal function. Her tympanic membrane perforation healed, and she's had no issues in the intervening time since. Our second case is DL, who is a 34-year-old male who received a shoulder to the right-hand side of his head after playing Gaelic football. He presented to Connolly Hospital with a depressed skull fracture on the right-hand side and acute onset of facial weakness. He reported that he was dazed after the injury, he did not lose consciousness, and hadn't had any nausea or vomiting after the event, and his GCS was 15 out of 15. On examination, he had a depressed skull fracture in the right temporal parietal area. He had a House-Brackman grade 6 or complete facial nerve paralysis on that right-hand side, with no other neurological deficits, and his ear he had right hemotympanum, tympanic membrane perforation, and blood in a distorted external auditory canal. CT of his brain and temporal bone was arranged. On the left-hand side, you can appreciate he's a comminuted, depressed fracture of his right squamous temporal bone with a small area of pneumocephalus, and it's not quite evident on this, but he also had a small area of extradural hemorrhage. In the right-hand picture, you can see that he's a transverse temporal bone fracture, and you can appreciate here disarticulation of his ossicles as well, evident on the scan. So he's discussed with both ourselves and neurosurgery here in Beaumont, and given his small area pneumocephalus and very small extradural hemorrhage, there was no intervention required from a neurosurgical point of view, and he was transferred to Beaumont under our care. On arrival, we commenced him again on high-dose steroids. We consulted ophthalmology for ongoing eye care, considering he couldn't close his eye. Audiometry showed a right maximal conductive hearing loss in that ear. And electrophysiologic testing on day 4 showed no signal in his facial nerve. So he was optimized and again planned for exploration and decompression of his facial nerve. This gentleman underwent a right-sided combined approach tympanoplasty. His facial nerve was noted to be intact and it was decompressed, and thankfully it was stimulating at the end of the procedure. His malleus and his incus were removed, and he had a cartilage sicler chain reconstruction and cartilage tympanoplasty in order to restore his hearing. Postoperatively, he recovered very well and his facial nerve function improved back to normal. His conductive hearing loss improved and he now has a small air-bone gap or minimal conductive hearing loss around 20 decibels, and his tympanic membrane perforation is healed. So temporal bone fractures are most commonly caused by blunt trauma. As with any trauma, they need to be managed in accordance with ATLS principles, managing threats to life first in an airway, breathing, circulation, systematic fashion. Anyone with a suspected temporal bone or skull-based fracture requires a full neurological assessment, including GCS, assessment of cranial nerves, and peripheral examination as well. On examination, findings that might point to a temporal bone or skull-based fractures, are raccoon eyes, battle sign, or hemotympanum. And salient symptoms for someone you suspect a temporal bone fracture in are related to the complications that may arise in these patients. These include facial nerve paralysis, hearing loss, vertigo, which potentially may indicate a perilymphatic fistula, or CSF otorrhea. These patients all require CT temporal bone and a CT brain at minimum, as 80 to 90% of them will have coexisting intracranial pathology. Where CT is unclear regarding facial nerve continuity, MRI can be useful, and if any framing are involved, angiography should be arranged. These patients also require audiometry to assess their hearing. Temporal bone fractures can be classified in a number of ways. Most commonly, you'll see them classified as either longitudinal or transverse, which is the orientation of the fracture relative to the petrous apex. It's not particularly useful in clinical practice, as most fractures are somewhat oblique, not parallel or perpendicular to the petrous apex exactly. More clinically meaningful classification is whether the otic capsule is involved or sparing. So if the otic capsule is involved, being the part of the ear with the cochlea and the vestibular organs, the patient is more likely to have a sensorineural hearing loss, facial nerve paralysis, vertigo, or a CSF leak. And thankfully, most temporal bone fractures spare the otic capsule. Around 5 to 10% of cases of temporal bone fracture will have a traumatic facial nerve injury. These patients need full clinical examination, particularly examining the nerve and grading their nerve function according to the House-Brackman scale. So this grades all aspects of facial nerve function from 1 to 6, with 1 being normal nerve function and 6 being no movement at all. The key distinction being between grade 3, which is asymmetry but an eye that is able to close, and grade 4, where their eye isn't able to close and they'll need lubricating drops and taping their eyes shut at night. These patients should also require nerve conduction studies. So electrophysiologic testing can be particularly useful in cases where there's a complete facial nerve paralysis. It can be done in electroneuronography or ENOG or electromyography or EMG, and it's best done 3 to 14 days after the injury, which allows for Wallerian degeneration to occur, as testing isn't always accurate in the initial phases. In someone with a complete cranial nerve paralysis, or cranial nerve 7 paralysis, I should say, the management will be according to the degree of nerve injury on their nerve testing. So if there's a greater than 90% loss of nerve function on ENOG or absent muscle unit potentials on EMG, they're unlikely to recover without some form of surgical intervention, and surgery is indeed warranted. In general, for patients who can't close their eye, we need to consider eye protection by form of lubricating drops and taping their eyes shut at night. All patients with a facial nerve injury related to trauma or facial nerve injury in general should be commenced on high-dose steroids. ENT UK currently recommends 60 milligrams of prednisolone for 5 days, followed by a reducing dose for a further 5 days. Any further intervention is dependent on if they have a complete or a House-Brackman grade 6 palsy, or if the nerve palsy is delayed or immediate in onset. So patients who are a suitable candidate for nerve decompression are patients with an acute onset, complete paralysis, who are neurologically otherwise well, CT showing a displaced fracture traversing the facial nerve on CT, and no response on nerve conduction studies. Patients who are likely to do well with conservative management are patients with an acute onset incomplete palsy, a delayed onset complete palsy, or delayed onset incomplete palsy. And the reason being is, in these cases, the loss of nerve function is largely due to edema of the nerve within the fallopian canal. Patients who have an acute onset complete palsy don't always undergo surgical intervention and may be best served with conservative treatment. And these are patients who are otherwise neurologically unwell, who have an ongoing CSF leak, or if there's no clear history regarding the onset of their palsy. With regards to steroids, there's good evidence that early use of steroids in patients with traumatic facial nerve paralysis is critical, as evidenced by this study by Lee et al., where steroid therapy within 24 hours markedly increased the chance of a full recovery of nerve after a traumatic facial nerve injury. With regards to the dose, we don't have any particularly good evidence to decide what dose exact we should give, as evidenced by this study by Nam et al., which shows that there's no difference in the recovery of nerve function in patients who are conservative management, irrespective of the steroid dose used. With regards to timing of our surgery for patients who have an acute onset complete facial nerve paralysis and need surgery, it's pretty evident within the literature that early surgery, i.e. surgery performed within 2 weeks of the incident, results in markedly improved outcomes in terms of facial nerve function for patients. Unfortunately, not all patients will achieve a good outcome and have recovery in their facial nerve function. And in these cases, we consult our plastics colleagues, who in Beaumont here would be Mr. Fiacre Martin, Mr. Brian Neefsey, or Barry O'Sullivan, who run a facial palsy clinic here. Facial reanimation can be done in a static or dynamic manner, depending on how long the injury has been there for and if the nerve is in continuity or not. Static procedures include Botox, brow lift, gold-weighted tarsal plate, or an oral commissure suspension sling, with the goal of achieving symmetry in facial appearance, while dynamic repairs aren't commonly done for patients who have an established palsy, but can be done in the form of an end-to-end anastomosis or a nerve transfer graft using the great auricular nerve or the sural nerve. So I'd like to thank you all for your attention, and I'm more than happy to take any questions.
Thank you, Owen. That was very clear and concise, and I really appreciate that. It has cleared a few things in my mind. I was going to ask you how soon was the optimum time for this exploration decompression, but you've answered all that. I'll open it to the floor in a second, but just one question is, in the second case, very interesting case, that you said that, if I heard correctly, that you removed the incus and the malleus and his hearing improved. Did I get that right?
Yeah, that'd be correct. So,
explain the mechanism of that, because I thought if you remove some obstacles, then you wouldn't be able to hear.
Maybe I'll come in there. Yeah. So first of all, thank you very much, Owen, for that excellent presentation. Great to be involved in the neurotrauma. And I suppose with that particular case, the malleus and incus were completely articulated, and essentially they were functioning. So by using a disc of cartilage which we can place on the stapes head, and then you're placing, well, the eardrum is placed over that, you get direct sound transmission from ear canal to eardrum to cartilage to stapes. Now, with the first case, I just turned the incus around and I did an incus transmission, and that worked quite well on the particular case. I suppose if there's one message we really want to get across, these are highly complex patients, and when should they be referred for early surgical intervention? So just to reiterate what Owen said, if somebody presents with an acute onset complete facial that are neurologically well, very clear history, or somebody who presents with an acute onset ridicule of bone impinging on the nerve or with a displaced temporal bone fracture, then we recommend referral to us for consideration or intervention. Now, timing is controversial. Historically, it used to be advised when the next daylight, but people are pushing it out now for a week or 2 weeks. But equally, the message where conservative is adopted is very important. So if they have an acute onset but it's incomplete palsy, or delayed onset complete palsy, or delayed onset incomplete palsy, or if they're neurologically very unwell, quite often the case, or there's no clear history as to the onset, then we tend to adopt a conservative approach. And I suppose the final point I'll make on this particular issue is that these patients have multiple injuries with a severe head injury. They're often neurologically unwell. The palsy is often only detected once they come off the ventilator machine and are extubated. Then there's often no clear history. So the priority in those cases is to manage those other serious issues first.
I agree. The few that I can remember, they've always been on a ventilator, or they're the ones that would come our way anyway. And then when you take them off the ventilator, then it becomes apparent because we're focusing on their life-threatening neurosurgical injuries. One final question for me before I throw it out to the floor. Are there any other units in the country that are doing this facial decompression?
Well, we're very happy to accept referrals from all over the country, and indeed we do. And, you know, we have an open door policy, and we encourage colleagues with patients such as these to get on the phone straight away to us, and we're happy to see them straight away. And what we do with them, the actual, in terms of surgical approach, depends on what we find. But the majority just tend to have edema or bruising or a hematoma of the nerve, and by skeletonizing the nerve and decompressing it, together with incising the epineurial sheath for about 5 or 10 millimeters either side, that suffices. But in the small number where perhaps the nerve is disrupted, especially where the damage is over 1/3 of the diameter, we would then recommend mobilizing, freshening the ends and trying to oppose the two ends without tension. But if it's not possible to oppose the two ends without tension, then we're talking about placing an interposition cable graft, such as greater auricular nerve between the two ends.
The only facial nerve reconstruction I've been involved with was the hypoglossal facial nerve reconstruction with precision years back. But that was after a facial palsy, after a large acoustic. That was a great 2 cases there, Owen and Rory. I will put it out to the floor. Is there any questions involved? Anybody have any questions? There's nothing on the chat line, but does anybody have any questions? Patients who've got facial paralysis, whether it's post-traumatic or iatrogenic, is a huge burden to them, and it's very disfiguring, and there's a huge psychological component to it.
Yeah, that's correct. And I think it's great to have a referral service available where we're able, willing to deal with the. Just a few other points, I suppose. Many of the patients will have disruption to the ossicles. We recommend reconstructing that at the same time. Fractures through the internal auditory canal, thankfully, are very rare. But in those cases where it's an acute onset complete and the fracture goes to the IAM, if there's a dead ear, then we can decompress the nerve by doing a translabyrinthine approach. But if the hearing was normal, that we'd approach it as if you like, a middle fossa approach.
Thanks, Roy. That was very insightful. If there's no further questions, I'm going to thank Rory and Owen. Thank you immensely. And at this point in time, I'd invite anybody else who's from any other department in any other part of the country that they would like to present a case of neurosurgical interest. Please contact either Mohsen or myself, and we'd love to hear from you. Okay, thank you very much, Rory and Owen. I'm now going to invite Professor Michael O'Sullivan, consultant neurosurgeon at CUH, and he's got a great topic called Rescue ICP or Rescue Scalp. And I believe Mr. Michael Moo, one of our SPRs, is going to give us a chat on this. So you're very welcome, guys, from Paul. Are you with us, Michael? The two mixing calls.
Yeah, my apologies. I just had a bit of an issue with my internet connection.
Okay, Mike.
I'll just confirm if you can see my screen.
Yes, we can, Mike.
All right. Yeah, thanks very much. I'm presenting on behalf of Professor Sullivan. This is a case of a young man who was managed under his care just before Christmas. So our patient is a 29-year-old restrained driver involved in a single vehicle RTA where his car collided head-on with the central reservation barrier on the motorway. He was reported as being unresponsive by the bystanders and with obvious signs of head injury. When the paramedics got to him, going through the ABCs, he had a partial airway obstruction with some respiratory compromise. His blood pressure was not recordable, and he was quite tachycardic with a GCS of 8, localizing and with sluggish pupils. The paramedics felt that he had a pneumothorax bilaterally, so they performed needle decompression bilaterally on the scene. On arrival to the nearest emergency department, he was rapidly intubated by the anesthetic team. He was found to have clinically tracheal deviation to the left, and subsequent imaging confirmed bilateral hemopneumothorax greater on the right-hand side. His GCS at this stage was 5, with a decorticate posturing and sluggish pupils. It was also obvious that he had extensive scalp injury, as well as a olecranon fracture on the right-hand side, quite acidotic on his blood gas. So this is his non-contrast CT brain, which shows thin bilateral acute subdural hematoma, slightly larger on the left-hand side. There's also evidence of some blood within the intrapeduncle cistern, but his basal cisterns here are nicely open with good sulcal jarl pattern at the top, although it's slightly effaced for his age. This is a plain radiograph of his right elbow and wrist, confirming the fractures. And the rest of his trauma series, he had a right first rib fracture, in addition to the bilateral hemopneumothoraces. Spine-wise, he had a type 1 occipital condyle fracture. He had a fracture through the pars interarticularis at C3 on the right-hand side. And he also had some compression fractures of his T2 to T7 vertebral bodies. At this stage, he was discussed with us. We accepted him for transfer immediately. However, he was quite unstable for transfer. His hemoglobin was 6.7, so we'd advised that it was stabilized from a hemodynamic perspective at a referring hospital. So he was transfused and sedated in their ICU overnight, and was transferred to us once he was stable from a cardiorespiratory point of view. Our plan with him, given that scans based on the 3rd and 4th editions of the severe brain injury guidelines from the Brain Trauma Foundation, was to insert an ICP probe to guide his management, because in the 4th edition, the ICPs have been kind of recommended in order to reduce in-hospital mortality and 2-week mortality post-injury. But we're still pretty much going by the third edition guidelines, which states that all severe TBI patients with abnormal scan, DCS less than 8, should be ICP monitored. And also in a certain subgroup of severe TBI patients with normal CT scans. So this gentleman certainly fits into the group of normal scan, although I'll touch on this a bit later on. So when he arrived, we brought him straight into the operating theatre. And fortunately, the extensive scalp laceration that was advertised to us was certainly more extensive than we had bargained for. It was obvious at this stage that this wasn't just for the neurosurgery registrar. We got our plastic surgeons involved, as well as the orthopedic surgeon for his limb injuries. And we made a decision on the table to essentially insert a right frontal ICP probe away from this scalp injury. And the plastic surgery team would, I suppose, assess his scalp on a day-to-day basis based on what his ICPs were. So why ICP monitoring? There's actually no great high-level evidence supporting it. The only randomized control trial on ICP monitoring was the one performed in South America, the BESTRIC trial, which actually showed no difference between patients who are ICP monitored versus patients who are managed based on their clinical examination and imaging findings. There are other studies like the one that shows clear evidence for ICP monitoring, but these are retrospective studies or propensity matched prospective studies. So it is still common practice where it is advised by the Brain Trauma Foundation that we should ICP monitor those patients. Because it's not just the ICP monitoring that improves outcome in these patients. It's actually what we do with that number and the waveform and how it helps to guide management. So for the next 72 hours for this patient, we stuck to the ETF guidelines and the Seattle consensus guidelines, and keeping his ICPs less than 22. He received more blood transfusion. Unfortunately, developed ventilator-associated pneumonia, which is not uncommon with these patients. This was treated with antibiotics. Our orthopedic colleagues washed out his elbow wound. They were quite eager to bring him to theatre to fix it, but unfortunately, his intracranial injuries took more priority. He became hypotensive. This was corrected with hypertonic saline. Around day 6 to 9, we started to run into trouble with his intracranial pressure with spikes over 20, sometimes sustained longer than 5 to 10 minutes. But he was quite sensitive to his serum sodium concentrations, so we were able to control it during this time period with boluses of hypertonic saline and sometimes mannitol, and in some cases boluses of sedation with propofol. So we repeated his intracranial imaging, and one might say that it's actually index scan. The subdurals haven't expanded. His cortical subarachnoid blood barely visible. His contusions have matured a little bit, as you would expect, but his basal cisterns, as you can see here, are widely open, with no evidence of transtentorial herniation. This is what sometimes we will refer to as a relatively low pressure scan. So it wasn't making sense why we were looking at a scan that looked relatively low pressure, but with high ICP readings. Again, we went back to the evidence, and we know that patients who have decisions made based on their clinical imaging and clinical examination did just as well as patients who had ICP monitoring. So although our rescue ICP trial would have asked us to perform a decompression on this gentleman, a combination of the fact that the clinical and radiological findings didn't match with the ICP readings, as well as the dog's dinner, that is scalp, and performing a decompressive craniectomy and the potential complications that will create for both ourselves and the plastic surgery team, we decided to hold off. So again, back to the guidelines. The guidelines recommends ICP in patients with abnormal CT scans. The earlier guidelines, the second and third edition, didn't actually fully explain what abnormal CT means. You look at the literature, some authors would disregard traumatic subarachnoid blood or small contusions as being abnormal, and using a Marshall classification that's shown here, some authors would only classify a scan as being abnormal if there was a relatively large mass lesion, like a subdural or an extradural, with or without effacement of the basal cisterns. The recommendations in the BTF goes back to evidence from the 80s. There was a study from Narayan and his colleagues where they reported that about up to 20% of patients with normal CT scans on admission will develop intracranial hypertension. The criticisms for this study was actually that they were using first generation CT scanners, and that some of these patients who were, in inverted comma, normal scans might have actually had contusions that were not detectable by the low quality CT scans in the 80s. But then this study published by Professor Sullivan in Edinburgh, whereby they looked at patients who had normal scans on admission, and almost all of them had episodes of intracranial hypertension within the first 5 days of monitoring, and 5 out of 8 of them also had compromise with regards to cerebral perfusion pressure. So it wasn't just that we weren't picking up these small injuries. Patients with normal scans do get cerebral swelling based on the complex pathophysiology that's associated with TBI. We still don't have high level evidence to allow for this to essentially to guide management. So the Milan consensus in 2014 with regards to normal scans then advised that we should consider doing a second CT, and only if that second CT is worse should we start with intracranial pressure monitoring. And it was after this guidelines that we essentially added there's kind of the 3 subgroups of patients who, when you look at the evidence, including the paper from Professor Sullivan, so patients with chest injuries, patients with hypoxia, patients with hypotension, and patients with abnormal posturing seems to be prognostic indicators for developing intracranial hypertension later on in their management. The time course for intracranial hypertension from the literature seems to be reach its peak within day 3 to day 5. So here we are in our patient at day 9 managing intracranial hypertension. From the Seattle Consensus Conference, again, because there are no randomized control trials on these questions, the question is, when do we discontinue ICP monitoring after it's been started? And most of the experts who manage TBI patients would feel comfortable discontinuing this after 72 hours. Our patients would fit in the I suppose ICP acceptable greater than 72 hours, and also in the diffuse injury 3 category here, which is based on the Marshall classification system that I showed a few slides ago. So, this conference essentially when we can't perform RCTs, we get a lot of experts together and they vote on what they will do based on their experience. It's quite clear that most of our international colleagues would discontinue ICP monitoring at this stage. So we repeated this CT scan, and yet again, very similar to the scan. No concerning evidence radiologically of raised intracranial pressure. So we commenced thiopentone. So we moved to the third tier of TBI management, which was either decompression or barbiturate coma. So we opted for thiopentone. We changed this probe in the hope that this might be a malfunction probe. Unfortunately, is intracranial pressure remained persistently high, going up to sometimes even mid-30s to 40. So there is a term that was coined in one of the TBI conferences, where if we can't practice evidence-based medicine, if we don't have RCTs or good quality studies to guide our management, then we should practice medicine-based evidence. And essentially what this means is go back to experience. Professor Sullivan was quite experienced in managing head injury patients. So we decided to discontinue ICP monitoring, just like a lot of pushback from our neurointensivist. We also know from the literature that these probes, after about 5 to 7 days, they tend to drift, and in up to 20% of these patients, the reading we're getting is actually not the accurate reading. This is well described in the literature. So we replaced this ICP probe on day 16. A few minutes before replacing it, it was reading 23. And as it went back in, it read 6, which meant that this was a probe malfunction all along. Now, in the meantime, he had actually had a probe change on day 7, which also kind of continued to read persistently high. So we decided to proceed with his plastic surgery, given that we were now happy that he's come through his phases of intracranial hypertension. Our plastic surgeons performed a split thickness skin graft from his right thigh with a biodegradable matrix on the scalp, as well as on his elbow injury. He had treatment for endocrinopathies by our endocrinologist, and his fractures were managed conservatively because he'd been lying for a significant amount of time. It started to heal. Now, his ICP bolt was removed on day 7. His sedation was weaned, and on day 25, he was obeying commands. His scalp was satisfactorily extubated on day 21 and discharged to the ward with GCS 14, and was transferred back to the Burn Hospital, where he's currently undergoing rehabilitation. And he's now GCS 15, mobilizing with assistance of 1. This case kind of emphasizes the easy TBI cases are the ones with massive mass lesions that you make the decision to open the head and evacuate the hematoma. Cases like this can be quite complex to manage, despite having various different guidelines and algorithms, and that's because one size doesn't fit all with TBI management. ICP monitoring itself is not actually what improves outcomes, but it's the interpretation, is what we use with the figures and the waveforms and the information that the monitoring gives us. Thank you very much for your attention.
Thank you, Mike. That was a great presentation, and it just goes to show the limitations of just using an ICP monitor. It's much more nuanced. You have to look at the whole picture, just the clinical picture. I mean, this guy had serious thoracic injuries. I'm sure that contributed perhaps to his raised ICP. I mean, you had the ICP in there for 6 or 7 days, and then it got you know, the ICP pressures went up. CT scan looked okay. It's still a low pressure scan. I mean, would you not tempted to say this monitor is giving us spurious results? And would you not, even though he's got orthopedic injuries, cervical injuries, thoracic injuries, stable, I take it, thoracic injuries, what else, orthopedic injuries, would you not tempted to just, and scalp injuries, were you not tempted just to wean him and just see what he's like functionally?
So we actually changed the probe on day 7, and I did the probe change myself, and his regions before we changed the probe was I think 24, 25, and when we put the new probe in, it was 40. I got a fright, thinking maybe I'd caused more damage. So I think with the probe change, we were a bit concerned that even after a new probe went in, that we were still getting quite high readings. And there's been a case presented at this forum in the past by Mr. Sweeney, quite a similar case, except that that gentleman had the Lomborg A phenomenon with the, I suppose, the cyclical rises in ICP sustained at kind of 50 and then, you know, spontaneously dropping down. So that was in the back of our head. Was this a Lomborg A phenomenon that might need a decompression at some stage? So that was the reason why we kind of persisted a little bit, I think.
Okay, thanks very much, Michael. I'll open it to the floor, or does Professor Michael O'Sullivan have any comments to make?
Hi, David. Very difficult case. We didn't think he'd survive. So decompressive craniotomy was never on the cards, I think, because of his low GCS. He was hypoxic. He was acidotic when he came in. So I thought he was going to have a very bad outcome. So I thought we'd just do the minimal ICP monitoring, keep his CPP up and just see what happened, expecting him to pass away. But that didn't happen. So the longer we had him with us, then the decision making became more difficult and very difficult then to pull back. But Douglas Miller, who I had great respect for and probably knew more about the traumatic brain injured patient than anybody else, he would accept any ICP up to about 35 after 48 hours. So he would try and keep it under 20 for the first 48, but after that he would accept 35. And he was saying, you know, people going around with benign intracranial hypertension of ICPs of 40, no difficulty at all. So as long as you're keeping the CPP up and the brain perfused, keep going. That was the rationale.
That's a good point, Mike. I remember Douglas Miller very well. I'm going to open it to the floor. Has anybody got any questions? There's nothing on the chat line so far. Any questions at all? Very interesting case. Any questions about ICP for the two speakers? Indications for, as I said, if you don't treat a patient purely on ICP or CPP, which is cerebral perfusion pressure, you stand back, look at the whole picture, look at the trends, look at the wave patterns, see the response to various simple parameters, whether it's mannitol or hyperventilating them. Any questions from the floor? Okay, in that case, I'm going to thank Michael Sullivan and Michael Lamu. Fantastic. It's great to have this chat. Great that you're presenting up here. Hope to see you back here again next month. And as I said to you earlier on, if anybody outside Beaumont doesn't have to be neurosurgical, if you have any questions or you have any cases you want to present that may be of interest to the audience in general, please email Mohsen Javapur, that's mohsenjavapur@beaumont.ie, or myself, Taylor Bryan @beaumont.ie. I'll just see one chat here. It's just a thank you from Ming. Thanks, Ming, for saying thank you. Okay, I'm going to wrap it up then. Thank you very much, everybody. Good night.